Hello. Chapter 31 concerns assessment of children and adolescents, and you probably won't be able to use this much until you get to Senior 1. I am not an expert on children or adolescents by any means. I have had very little to do with them, but I'll give you what I can here. And when you get to PD, and especially yeah, in Senior 1, when you get to PD, especially if you end up working PD, you'll get a lot more. But this will give you a foundation to build on. Some of the changes that occur when the baby stops being an infant. Remember, the infant stage lasts until 1 year, and then after 1 year, then we're out of the infant stage. So the skin develops a tighter bond with the dermis than was present in the infant, but it's much smoother and less hair. Hair is less coarse than the adult. That starts to change in adolescence with the onset of sebum production. The apocrine glands become active, and so then the child is going to start moving toward adult characteristics. The head and neck, the head reaches 90% of its adult size by age 6, which sounds pretty remarkable, but look at children. Young children, their heads are disproportionately large compared with adults for the rest of their body. The toddler, the face appears small, but it will grow disproportionately during the preschool years. I think that's a typo there. It should be preschool. And then lymph tissue exceeds adult size up until before puberty. Lymph tissue is going to exceed adult size in proportion to their body. So that tells us that lymph nodes are probably going to be more palpable, more accessible than they would in the adult. As far as the ear, eye, nose, throat, the eyes, visual acuity reaches 20/20 by about age 6 or 7. So when your toddler and your preschool child is not going to, you can't expect them to have good distance vision. The inner ear matures in the preschool period, toddler period, and preschool period, and the eustachian tube is going to lengthen, and the pinna, by the time they get to school age, the pinna can be pulled back and up instead of back and down. And then nasal cartilage grows during adolescence. Sinuses, tonsils, and adenoids are also going to be increasing in size. Remember, we said that in the infant, newborn and the infant, the tonsils are barely visible. We have 20 deciduous teeth, and those are going to be replaced by 32 permanent teeth. And that usually begins in the preschool area, preschool stage, and it will reach its completion in adolescence. Alveoli continue to form until age 8. So a child that has problems with respiration and the alveoli are affected, they can regenerate and continue to grow alveoli up to age 8. The chest walls are thin with soft ribs, and the xiphoid process is movable, and children will have smaller airways, and so that's one reason that children are more susceptible to respiratory arrest. Remember that in the adult, cardiac arrest is more common than respiratory arrest, but in the child and baby, it's exactly the opposite. Respiratory arrest is more common. The children are abdominal breathers until age 7, and their respiratory rate is much more rapid than the adult. Respiratory rate lowers around ages 8 to 10. Well, it's going to gradually go down, as we'll see later on. And then the apical area, the apex of the heart is in the fourth intercostal space and to the left of the midsternal line, but it's going to slowly reach the fifth intercostal space by age 7. Heart sounds are louder because of that thin chest wall. They're higher pitched and they're of shorter duration, which makes sense since the heart rate is much rapider. There can be normal physiologic splitting of S2, and you might also hear S3. And you might hear what we call innocent murmurs, which are murmurs that in the absence of any other sign of cardiac disease. You may have an irregular rate. That's especially true of adolescents. And the heart rate will drop down to about 85 by age 8. And then by adolescence it reaches basically the normal adult rate. Breasts are going to be small in both sexes, both genders, until telarc. Telarc is when breast development begins, and that's the beginning of puberty in the girl. And it occurs anywhere from 8 to 13, and it's due to stimulation by estrogen. It's common for the breast to develop asymmetrically, so if you get a girl who is panicking for that reason, you can reassure her that that eventually the other breast will catch up. As you can imagine, breast development, or as you may know, this can be a distressing thing. All these changes can be very stressful. When they're occurring and they're not occurring, when it's happening with your peers and it hasn't happened with you yet. It's stressful both ways. With males, we may see gynecomastia, which is the development of female-like breasts. Usually this is temporary, and it can be just happening due to the hormones, but it can also be associated with use of marijuana or anabolic steroids. So if as you can imagine, when this does occur, this can also be a stressful occurrence, and it can also be the occasion for a lot of bullying behavior from peers too. As far as the abdomen, with small children the abdomen is cylindrical and it's very prominent when standing up. It will flatten when they're supine. That's the toddlers know. The toddlers have this pot belly appearance, but by preschool, why, they may still have this cylindrical prominent abdomen when they're standing up, but when they lie supine, you should see it go flat. And by adolescence, it assumes its adult shape. In young children, the tip of the right kidney may be palpable, especially during inspiration. And on the right costal margin, about 1 to 2 centimeters below, that's where you're going to try to palpate the liver. And on the left side, the spleen. You may or may not be able to palpate those. Take a look at pages 762 to 764, and those will show Tanner's stages of maturity for both for boys and girls, and as far as breasts and pubic development. With boys, the first thing is usually going to be testicular enlargement, and there will be some of that in the pre-puberty stage, and then when puberty comes, why it will be more. Puberty begins with boys with pubic hair development, and then following that you'll see penile and more testicular enlargement, and then the boy will start having emissions of semen, and then finally development of axillary and facial hair. During this phase, the prostate is going to approximately double in size. With girls, puberty begins with telarch, as we mentioned. Then pubic hair starts to develop, then axillary hair, and finally menarche, although there are probably exceptions. Some people may develop a little different order, but that's roughly the order that they're going to go in. As far as musculoskeletal system, small children have a higher proportion of cartilage, and their bones are much more flexible. They don't break as easily. When they do break, they repair more easily, more quickly, and more easily. And so when they do have fractures, it's fairly common to have what's called a green stick fracture, where if you think about a tree, if the wood is dry, it just kind of snaps. And that would be similar to a fracture in an older person. But the green stick fracture, think about if the stick is green, it isn't going to snap. It may come apart on one side and still have some connection there on the other side. So that would be a lot of fractures in small children are like that. Bones grow both in diameter and length, and they actually will continue to grow until about age 20, perhaps, when the growth ceases. The anterior curve in the lumbar region develops at about 12 to 18 months when the toddler begins to stand up. Remember, previous to this, they just had one C-shaped curve for the whole spine. And so then when they start standing, they're going to develop the anterior curve. Motor control develops first in the head, then the neck, then trunk, then extremities. As far as growth patterns, toddlers have growth spurts and then lags. They'll have periods of spurts and lags. They reach about half of the height they're going to be by age 2. And by 2.5 years, their birth weight has quadrupled. Preschool children, about at 4 years old, they should be, or they'll probably be about 40 inches tall and about 37 pounds. Usually preschoolers are slender. During school age, the girls outgrow the boys. Growth is there's rapid uneven growth in ages 10 to 13, until ages 10 to 13. Adolescence growth will continue until ages 18 to 20, and they add on about 20 to 25% of their adult height during this period of adolescence, and they can add on 30 to 50% of their adult weight also during this period of time. Some of the milestones, now remember that we talked about when we were talking about the infant, we talked about the Denver developmental screening test, and you're going to continue using that throughout childhood, and it has a lot of milestones and the age where the majority of children will reach those milestones. So one of those is walking unassisted, and then building a 2-block tower, and that occurs at about 15 months. Walking upstairs with the handheld and building a 3 to 4-block tower, 18 months. They can walk up and down one step at a time, and they can imitate a vertical stroke of a pen or pencil, crayon, by 24 months. Then jumping with both feet, or copying across, or doing an 8-block tower by about 30 months. Riding a tricycle, standing on one foot, doing a 10-block tower, or copying a circle by 3 years. Then skipping, hopping, catching a ball, lacing shoes, copying a square shape at 4 years. And skipping on alternate feet, throwing balls, using scissors well by 5 years. Then it gets a little shakier at school age because it's going to vary more based on, but bicycling, roller skating, writing script with script, like meaning the cursive style writing, that develops during school age. Then by adolescence, gross motor skills are at adult levels, and the fine motor skills will continue to be refined. As far as cognitive and language, at 15 months they have expressive jargon, meaning they're not forming, they may have a few words, but they're not forming proper words per se, but you can kind of understand what they're getting at if you know them. They have a lot of their own little invented words. At 2 years, they'll have about a 300-word vocabulary, and they'll be using 2 to 3 word phrases. They're not actually forming sentences, not using pronouns. They may use some nouns as pronouns, like if they are familiar with a dog, they'll call any animal a dog, or if they're familiar with, they may call, all men dads, or all women moms, or things like that. In the preschool area, the age, they first start out in the pre-operational thought, and then that has sub-phases, preconceptional phase, and that it's very primitive conceptions, where they associate simultaneous events, meaning that if it's their birthday, they got a birthday cake and it rains, why then they think they should get a cake every time it rains, or that if they get a cake they'll think it's going to rain, that sort of thing that day. They're very egocentric at this point, and they think that everything relates to them, and that can be very dangerous. Like, for example, if the parents are fighting a lot, they may think that it's about them, So that they misinterpret things in that way. Then in the intuitive, still in pre-operational thought, but in the intuitive phase, they start classifying and quantifying and relating things, but in a very naive way, where it's not what we would consider a realistic classifying or quantifying, but they start to do that. With school age, we enter concrete operations. They start doing inductive reasoning, meaning they're reasoning from the things they observe to generals. They don't really yet know how to reason from generals to particulars, so deductive reasoning, they still haven't gotten there yet. But they start doing some logical operations, but they have difficulty dealing with remote or hypothetical things. They're still very concrete in their thinking. Formal adult articulation patterns, meaning using proper sentences and you forming proper questions and that sort of thing, that develops ages 7 to 9. And then the stage of formal operations occurs between ages 11 and 15. And in substage 1, they're able to do inverses, understand inverses and reciprocals, meaning that they understand inverse relationships, or they understand that 1/5 is the reciprocal of 5. They begin to understand that sort of relationship. Substage 2, they can order triads, 3-point propositions or 3-point relationships. And then substage 3, they develop the capacity for true formal thought. But even then, as adolescents, they start forming all kinds of theories and thinking. They start playing with this abstract thought and formal thought, but they don't really get too much beyond their present. They're very egocentric in a new way. I mean, they can now, like the school child, is able to infer and think beyond himself, but then the adolescent, it's almost they've regressed in a way where everything it relates to them, everything is about them. I mean, they're just kind of coming back and recapitulating that, and they're certainly at a higher level, but they don't think about long-term consequences. They know, like they know that 40 years, like they can tell you all about lung cancer happening in 40 years to smokers, but it's much more important to look cool with that cigarette right now, because 40 years from now is just not even real. 40 years, they don't, that's not a meaningful concept to them, except in the abstract. The toddler, moral development. So the toddler is pre-conventional. Focus is on punishment and obedience. Sorry for the typo there. And they're mainly just focused on the immediate consequences. And the best thing to do is avoid punishment as much as you can. Offer simple explanations of why something is wrong, and use a lot of distraction, and praise appropriate behaviors and things you want to see. Reward that. But yeah, punishment is going to set up some negative things. It's going to give them maybe possibly a permanent negative attitude toward authority and toward and some parents, for example, they realize this, that they if they use physical punishment, that's going to just make this toddler more defiant and give her or him a bad attitude. And so then they start trying to use like withdrawing affection or withdrawing love. That is another mistake. That's going to cause that toddler to not have confidence in the world. So yeah, it's best to just stay away from punishment as much as possible. With preschool, they move into the pre-conventional conscience. Well, they're in the pre-conventional still, but conscience emerges rather than that immediate punishment and obedience focus. They start developing the internal parent inside that is, and they start, oh no, you shouldn't do that, and they'll tell each other this, oh, you shouldn't. Uh, they're still very much they're still mostly focused on external control, but they're starting to have conscience, and they're also still focused on punishments and rewards, and that's pretty much their conception of morality at that point, where it's all about punishments and rewards. With school age, they move into conventional morality, meaning that conscience becomes stronger, their internal control becomes stronger, and they have a desire to please significant others, and whoever those significant others are in their lives. So they're very focused on pleasing those others, but their morality is pretty much outward directed, like, well, this is wrong because mommy says it's wrong, or this is wrong because the teacher says it's wrong, and this other thing is right because these other people say they're right. And then finally, with adolescence, we move into the post-conventional moral development, and they're finally able to negotiate conflicts. Like, say in the school age child has learned principles like, well, we should we should be helpful to people in need that are hungry, and then they also learn we should respect other people's property. And so the school child will maybe accept both of those principles, but if they see somebody that's truly in need stealing something to eat, why, the school child is probably going to think, well, that's wrong, they should do something else, they shouldn't steal. But the adolescent might decide, well, under these circumstances it's okay for that person to steal. Or they might say, no, it's not okay for them to steal, but they're able to see conflicting principles and resolve those. Their standards are now pretty firmly internal, and one of the essential tasks in adolescence is forming your own identity, of course. So you have all this moral system that your parents gave you, and you start perhaps experimenting with new moral standards and trying to decide, well, what is my parents' standard and what is my standard? And that holds true not only for morals, but also for other things, like they're constantly trying to define themselves against their parents, and sometimes it seems like they want to do everything opposite what their parents did, but that's mostly trying to experiment with seeing what is truly theirs and what is their own and what is their parents'. So they're just trying to differentiate that. Turning now to the psychosocial stages, which are these developmental tasks, which, remember, these are tasks that you have to resolve successfully. And if you're not successful, if you, like, say, if you fall on mistrust, why, you do move on, but that's going to be there in the background for the rest of your life. And then when you have stressful situations such as illness, many times you'll regress to a lower level. Like, you might be in preschool, but if you're in the hospital, you might go back to autonomy versus shame or doubt, or even trust versus mistrust, especially if you never fully resolved that in the first place. So the infant is, as we learned earlier, is Erickson's developmental task for them is trust versus mistrust. And so they have to learn that the world is a consistent place, that their parents are consistent, and that their needs are going to be met. And if that doesn't happen, then they're going to fall on the mistrust side, and that will severely handicap them the rest of their life. Toddlers, it's autonomy versus shame and doubt. They're starting to control their own bodies, to control their own actions, and this is their developmental task. And if they don't, if they are made to feel that shame, for example, like thinking of toilet training, if their mother, oh, you filthy little brat, if they get that kind of reaction, or if they get taught, oh, you're so stupid, you just can't do anything, if they get these kind of messages, why, then they may fall into that shame and doubt thing. And much as we try to be humanistic and progressive and all this, why, it's very easy to give those messages without intending to. Like, oh, no, I would never want to undermine my child's sense of autonomy. Oh, no, far be it from me. Kid, how many times do I have to tell you, and then you turning around and you don't even realize when you're doing it half the time. Then at the preschool period, the task is initiative versus guilt. So the child now has some control over his or her body. They've basically solved those problems. They're able to walk and talk and control their own actions and this sort of thing. So they solved the autonomy problem. Now they start showing initiative. They start doing all kinds of projects and doing dress up and playing with other kids and going out. And if they're made to feel that these initiatives are bad or foolish or whatever, then they may develop guilt for that. And sometimes, like, that could be, say, like if the child explores something and is made to feel shame, like particularly things like maybe they ask questions about, oh, well, mommy, why aren't we with the daddy I had before? We're with another daddy now. And, oh, shut up, you little kid, don't talk about things like that, Now, obviously, we don't want to go into all the details like we would with an adult, but we want to give age-appropriate explanations to them. Or sometimes preschool kids explore their own bodies or other kids' bodies and all that, and if you kind of yell, oh, you're doing sexual abuse of your friend there, or your, no, don't do that, only animals do that. Why, this can obviously result in guilt in those cases. Now, obviously, we do have to explain to them, well, no, those kind of things you're doing are inappropriate, uh, and again, probably your best friend at this time is distraction. When you don't want to make a big thing out of something that you know you shouldn't make a big thing of, but you do need to control it, why, a lot of times distraction works wonders. Find, if you know that if you know that this child is extremely interested in cars, then you could say, oh, look at that brand new car. What kind of car is that? And you'll have them completely off of whatever it was that you want to get them off of. Then school age, the task is industry versus inferiority. And here the focus, the onus is not so much, it's still on the parents. I mean, a lot of it's still on the parents, but here the teachers and the school system bear a lot of the onus, or a lot of the responsibility for appropriate development. And so the child now has initiative, and the school starts to slap that initiative down, like, here, do this work instead. This is what you should be doing. And the student, the child, oh, this is totally boring and it's useless. I could be out there collecting butterflies, and here I'm having to copy all these letters that are totally useless. So the idea is you obviously we have to educate school children, and not everything is going to always be fun. There's a lot of work that is tedious, and that they have to learn to accept this, but we should try to make learning as enjoyable and rewarding to them. If we don't make learning enjoyable or rewarding, the only thing we have left is using the stick. So like the carrot and the stick, you use the carrot a little bit more to encourage industry and learning. And then with adolescence, it's identity versus role diffusion. And by this time, neither the teacher nor the parent is that important. Now it's the peer group that's important. And hopefully, both the teacher and the parent, hopefully we have equipped this adolescent how to negotiate the peer group, because the peer group is taking over now, and the adolescent is trying to form a stable identity in the world and stable relationships. And adolescents that fail to form a stable identity are going to have problems in adult life. Then as far as Freud's stages, Freud had a theory of with the way psychosexual development occurs, and he placed the toddler in the anal stage, that the child actually gets pleasure from evacuating and from controlling evacuations, and it becomes a power struggle with the parents. And so and if this stage is resolved successfully, then they move on. If it's not resolved successfully, why then they're going to carry the scars of that later on in life, throughout there later on. In the preschool, they get into the phallic stage. Both boys and girls girls, according to in Freud's theory anyway, that girls imagine that they once had a penis that was castrated and cut off. And it's very complicated and doesn't really concern us right now. You'll learn all about that in psychiatric nursing. But and some people, it's kind of controversial too. Some people don't accept it. But anyway, the phallic stage is the center has moved from the anal pleasures. Now they're exploring this phallus, and they play doctor and nurse and all this kind of thing. And then in the of course, parents, if parents overreact during the phallic stage, oh, you horrible, filthy, sinful kid, why then that can get the person stuck in that stage, and they'll probably comply, but then it will come back out later on and come back out with a vengeance. Then also in the preschool, in this phallic stage, is when the Oedipus complex develops, and that involves the child the boy falls in love with his mother, but eventually when it's over he identifies with the father. He identifies. Girls fall in love with their father at that point, but eventually they come out of it and identify. Their identity is kind of tied up with their mother when they're out of it. And then the school age, they go into the latency period, where everything kind of calms down, and oh, my sweet little kid, he doesn't think about any filthy things, or my sweet little girl, she doesn't think about filthy things like that. And the parents are kind of lulled until adolescence hits, and then it's like, ah, what became of my sweet child? And then they're in the genital stage, which is progresses into adult psychosexual development. Or that is the way it's supposed to occur. Now, as we say, you can get blocked at these different stages, and that's where problems begin. As far as nutrition, by about 12 months, toddlers are probably eating the same, more or less the same things with the rest of the family. Now, of course, you'll have to mash the food and change the consistency of it, and there will be some things that the adults eat that the toddler doesn't, but they'll probably be eating with most of the rest of the family. Then at 18 they get picky, and sometimes parent and child have all kinds of food conflict at that time, and you want to make sure that they get an adequate diet, but you also want to avoid power struggles, because remember, that child is trying to establish autonomy, and they're also saying no to everything. They're in the no's. No, 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 I don't want to. Preschool requirements are very similar to that of the toddler. Food habits are going to begin to be influenced by others, where the toddler is probably going to be just rejecting things, saying, no, no, I don't want this, I don't want that, and the parents are probably fighting. With preschool, why then maybe instead of maybe you didn't give the preschool kids something that the adults are eating, and they, well, I want that. You can't have it. It's an adult thing. Why not? I want it, So that's when they also start to notice the social aspects of meals during this time. School age, their calorie requirements diminish in relation to body size. I mean, they're still eating more and they're growing, but and they also get exposed to broader eating experiences, because now they're eating in that lunch room at school, and so they're exposed to what other people eat and what other the kind of cooking that other people do, and so they start getting broader experiences. Then adolescents, again, they will typically eat whatever's available. They like to eat a lot because they start the school age, they aren't eating so much, and then adolescents, they start eating everything in sight. And then there's also a risk of fad diets, which can be for weight loss for sure. In some girls get anorexia and get eating disorders like that, and even some boys do too. But a lot of the fad diets may not necessarily be like when I was a teenager, the Zen macrobiotic diet, which was supposed to help you reach enlightenment or whatever. It was just a cool thing, and some people tried to just eat rice or things like that, and they got themselves in serious problems by doing that. Or and then like maybe vegetarianism or different spiritual or different other types of diets, or that whatever is, sometimes it's maybe a coolness factor rather than any desire to control weight or anything. Uh, Activity, exercise, and rest. So you'll want it when you're doing the assessment, just as with the adult, you'll want to find out what's the typical 24-hour day like, what's your activity pattern like, and then you'll pay it with children. You'll pay attention, like how much time on TV, how much time with video games, do they have any restrictions? Unfortunately, some parents basically use the TV as their babysitter, and it's a very convenient babysitter, and the poor kid gets little exercise, doesn't get enough rest, and is exposed to questionable TV content. Uh, Depending on the age, if they're school age, why, yeah, so you'll be asking about what about school activities? What are their, like, do they just go to school and come home? Or are they involved in extracurricular activities, or any chores that they are required to do? Work outside the home in the case of teenagers, maybe. Any sports, any hobbies, interests, that kind of thing. Then, as far as sleeping, where and with whom does the child sleep? And what type of bed? Sleep aids, as far as, do they have a teddy bear, a little special blanket? And do they do sleep rituals, like maybe have a glass of milk and say a prayer and then they go to sleep or something? And what are the bedtimes? What is waking time? Do they take naps? And if they have sleep disturbances like sleepwalking, talking in the sleep, waking up with nightmares. Toddlers usually average about 12 hours, and they'll usually take a nap in the afternoon or sometime. Preschool, about the same, 11 to 13 hours a day, take a nap, but sleep problems start to develop, and it's important to continue those bedtime rituals with the preschool kids. Then the school children, they're probably going to need less sleep, about 8 to 9.5 hours, depending on the child. And then adolescents, from a physical standpoint, they need more than the sleep than the school children do, but a lot of times they don't get it. And so you may think, well, you're a teenager, oh, this teenager is so lazy, all he wants to do is sleep. And it's what it is just that he's not getting enough sleep, and so when he does get a chance, he wants to sleep in. And so the solution to that is to get more regular sleep on a more regular basis. But by then, the child is more or less in control of his own schedule, and parents don't have a lot of influence on it necessarily. But sometimes you can be subtle and steer them in the direction you want to go in, and let them think it's coming from their own, let them think it's their own idea maybe. Other things that you want to assess with children and adolescents: socioeconomic situation. That's important, and that's the family's socioeconomic situation. Some of the things there would be housing, occupations of the parents, that type of thing. Family structure. Do the parents live together? The family that the child lives with, is it two-parent, single mother, extended family with numerous relatives, there's all kinds of different family configurations. What kind of relationships does the child have? And how is their role development going? And then self-esteem, assessing the child's self-esteem and their development of their self-concept. And then also coping and stress management. And then the textbook has a number of questions that you can ask getting at that, and a discussion about that. So be sure to read all those things. Subjective data. Now, depending on the age, you'll probably interview both parent and child, and as the child gets older, you'll give more weight to the interview with the child. But in the case of discrepancies, why, then you're going to validate, because obviously if you ask a child, have you had any hospitalizations before, and they did, you're going to get a very different story from what you'd get from the parent. And even the parent's story may not be that accurate. And so if you had medical records, that would be wonderful. But you'd still want to get each person's story to see how they perceived it, and then get the medical record and say, oh, okay, so that's what went on. The chapter talks too about play as communication, where with very young children you may want to play with them, or do a little bit to see where they're at. And it's also the tip: try to get at eye level with the child. And then on page 778, there's a number of age-specific communication techniques to use. So you might want to, if you still have this book a year from now, why, you might want to look at that when you get to your PD clinical. And vital signs. So rule of thumb: age 3 months to 2 years, the heart rate is anywhere from 80 to 159. That 80 looks a little low to me, but yeah, certainly with a newborn, anything less than 100 would be alarming. If when you have a newborn and you have less than 100 heart rate, that's alarming. These rates are at rest too, pretty much at rest. From 2 to 10 years, heart rate is going to be like 70 to 110. and from 10 years to adult, 55 to 90. Particularly athletic adolescents are going to have low heart rates, as will athletic adults. Respiratory rates, less than 1 year, probably about 30 to 53, 1 to 2 years, 22 to 37, 3 to 5, 20 to 28, and then 6 to 11, 18 to 25, and then the adolescent will have the same as the adult, 12 to 20. Systolic blood pressure, for 1 to 7 years, you're going to take the age in years and add 90. So 90 at 1 year, 91, 2 years, 92, 3 years, 93, etc. Then 7 to 18 years, you're going to double the age and add that to 90. So 18 years old would be what, 36 plus 90, 126. That would be pre-hypertensive actually, but these are just kind of rough estimates of what to expect. And certainly you will find adolescents and children that are pre-hypertensive. That unfortunately can happen. Then as far as diastolic blood pressures, 1 to 6, and it would be 53 to 66, and 6 to 18 would be their age in years plus 52. As far as the health history, the rest of this, like the health history and collecting objective data, we covered a lot of it when we talked about the infant in the last chapter, so I'm going to be going over it a lot. I'm going to be skipping a lot of things. The biographic data is pretty much exactly what you got with the infant. So now as the child gets older, you're going to modify it a little bit, but the history of present concern you would get, and that you'd pretty much follow the same pattern that you do with the adult, or even for history of present concern. And then with cold spot, you'd want to ask both the parent and the child, if possible, about the symptom. As now, things like the onset, a toddler is not, or even, well, a toddler couldn't tell you much at all, but a preschool child wouldn't maybe have a good handle on the onset, but you can ask. And he said, well, about a day, and the parent would know, actually he's been talking about this for 2 weeks. Ask, if the child complains of pain, ask the child to point with one finger to where it hurts. That's also a good technique to use for adults sometime too, but it's especially important with the child. As far as rating their pain, you don't use the number scale. Show them the Wong-Baker Faces scale and ask them. Now with an adolescent you could ask them to number their pain, or probably even a school child, you could probably ask them to rate their pain on a 1 to 10. The personal and family history is going to be much like what we've been doing with both with the infant and with the adult. And then lifestyle and health practices are going to vary depending on the age, what you'd ask there. With objective data, look at general appearance and behavior. Is it age appropriate? And then you do the developmental assessment, which we've already discussed. You'll do vital signs, height, weight, and compare them to the age-specific norms. Assess skin, hairs, and nail. As far as the head, it's important to see if it's normocephalic or not. There is a condition called hydrocephalus, which is characterized by an abnormally large head. And so that's something to be on the lookout for in this population. Inspect and palpate face and neck. Also with toddlers and young children, you want to look at head control. By the time they get to school age, that's not really an issue. The toddlers and then assess lips and palates. Remember, cleft lip and palate is one abnormality. Tongue, buccal mucosa, teeth and gums, throat and tonsils, nose and sinuses. Visual acuity at 1 year is the normal is about 2200, and then it will slowly go down to where by age 6 it should be 20/20. Are all school-aged children 20/20? No, indeed not. Some of them have unrecognized visual problems. The eye exam is going to be much like with the infant and then with the adult one. With as far as hearing, you'll do a whisper. You'll whisper something to them from about 8 feet away, and if they can answer that, why then they're okay. Otherwise, you might refer them for audiometric testing. Then you'll want to assess the shape of the thorax. And remember that children less than 7 are abdominal breathers, so abdominal breathing is normal for them. Percuss and auscultate lungs as usual. Inspect and palpate breasts. Until adolescence, there won't be any breast development. It will be just underdeveloped breasts. Inspect and palpate precordium and auscultate the heart as in the normal manner. Then abdomen. Up to 4 years, the abdomen is prominent both standing and supine. So it won't be flat, but then after about 4, it'll still be prominent when they're standing, but when they lay down it will be flat. Bowel sounds and the palpation of the abdomen is just like in the you're doing the same things as in the adult. When you get to genitalia exam, in young boys, the cremasteric reflex, which that's not just in young boys, that's in adults too, but what happens in young boys is that it can pull the testicles up into the inguinal canal. So in order to avoid that, ask the boy to sit with his knees flexed and abducted, and the cremasteric reflex will still happen, but it will be less so. With females, you're just going to do external genitalia exam unless there's a good reason to do an internal exam, such as suspected infections or suspected sexual abuse or things like that. When they're sexually active, that's when you begin the gynecological exam. And if it would be an experienced somebody experienced with the assessment that would be doing it. You wouldn't want to be doing it your first time on a young girl for sure. Anal exam, palpation, we just inspect. Palpation is usually not performed on children. Then you're going to assess the feet and the legs, spinal alignment, their gait, joints and muscles. level of consciousness and cerebral function, cranial nerves, assess these just as you would with an adult, and their deep tendon and superficial reflexes, balance and coordination, motor function, all these things just as with the adult. And then finally, there's the soft signs of neurological problems. And so these are signs that you will eventually outgrow, but uh, some people believe that we're kind of falsely labeling somebody with a neurological problem, but other people believe that these are signs that we should pay attention to, such as short attention span, poor coordination and position, hypoactivity, impulsiveness, emotional ability, distractibility. If they haven't demonstrated right-handed or left-handed, if they're just still using both hands without preferring one or the other. Although some people end up all through life that way, but it's not that common. Language and articulation problems, and then learning problems. So those are just things to note.